Okay. Now, the question is, which of the following is characteristic clinical feature of Dejerine syndrome? Now, this Dejerine syndrome is also known as medial medullary syndrome. So basically, it means the problem is in the medial side of the medulla. Now, generally, when we talk about the brainstem involvement, what we basically know is we can get contralateral. We can get this crossed hemiplegia, that too contralateral hemiplegia, ipsilateral cranial nerve deficits. But that is only possible when the pyramidal tract is involved. Okay. If you've gone through other questions, you might already know that in the brainstem is basically a collection of the cranial nerve nuclei and it is a conduit or pathway for ascending tracts to go up and descending tracts to come down. Right. So from spinal cord, the tracts are going up to the brain. From the brain, tracts are coming down to the spinal cord, and brainstem is acting as a pathway for them or the conduit. Okay. Now there are certain structures which pass through medially, certain structures which pass laterally. The structures that pass medially, you can remember them with 3 M's. Medial longitudinal fasciculus, then your motor pathway, and medial lemniscus. So for a physician, these two are important. Medial lemniscus, which is carrying the dorsal column sensation, and the motor pathway. So it is easy to remember, right? All of them have M. Medial longitudinal fasciculus, motor pathway, which is pyramidal tract, and your medial lemniscus. Okay. On the other hand, there are 3 structures which pass laterally. That stands for spinothalamic tract, which carries pain and temperature sensation. Then you have this sympathetic chain, which is concerned with the sympathetic nervous system. And then you have spinocerebellar tract. So 3 S's laterally, you can remember it with S for side, right? Side, laterally, 3 S's. M, medially, 3 M's. Okay, now when we are talking about medial medullary syndrome, the problem is on the medial side of the medulla, and it will be affecting mainly the M pathways, motor pathway, and your medial lemniscus, which is concerned with the dorsal column pathway, right? Okay, so now let us get back to the question. Do I expect the patient to have contralateral hemiparesis? Because one of the M is motor pathway that is getting involved, so I can have contralateral hemiplegia because this M, motor pathway or pyramidal tract, decussate at the base of medulla. So I can expect contralateral hemiparesis. Okay. Now, do I expect ipsilateral tongue muscle paralysis? Yes, I can expect ipsilateral tongue muscle paralysis because, see, remember, when it comes to cranial nerve palsy, the 3rd and 4th cranial nerve nuclei are present in the midbrain. So if there's a midbrain problem, you can have 3rd and 4th cranial nerve involvement. Now 5, 6, 7, 8 are present in the pons. So if there's a pontine problem, you can have involvement of these cranial nerve, right? Remaining 9, 10, 11 and 12 are present in the medulla. So these can be involved, right? So I can expect ipsilateral tongue muscle paralysis. Okay. Then contralateral impairment of tactile sensation. Contralateral impairment of tactile sensation. Okay. The tactile sensation here, we are basically talking about the medial lemniscus pathway and not the spinothalamic tract. Spinothalamic tract is present laterally, but the medial lemniscus is present medially, which is concerned with your fine touch and your vibration sensation and joint position sensation, which can be affected because even this medial lemniscus decussates at the base of the medulla, right? So from the spine, these dorsal column fibers ascend on the same side, but at the base of the medulla, they cross to the opposite side. So you can have that also, right? Contralateral impairment of tactile sensation. So option D becomes the right answer here. All these 3 can be seen in medial medullary syndrome or Dejerine syndrome. Okay. So that's it from me over here. I hope that helped you. Thank you.